So this story starts with a 20-year-old male brought to my OPD by his boss. The patient had suffered blunt trauma a year back but did not show anywhere. On examination, the patient seemed to be aphakic with a visual acuity of 1/60 which improved to 6/6 with a hyperopic correction. On anterior segment examination, in the given marked area, there was no lens or the anterior capsule and there was a very thin, fragile posterior capsule. The sulcus appeared very much intact with thick calcified margins. So on posterior segment examination, the disc and the macula appeared healthy. I checked the periphery, but there was no sign of the lens or the nucleus. So I was baffled. Where did the lens go? So I went through the literature and found a couple of articles where they have shown that there might be a spontaneous absorption of lens post blunt trauma. Hence, my plan of action for this case was to do a good vitrectomy, check the patency of the sulcus intraoperatively and put a 3-piece IOL in the sulcus and completing the case with a good posterior capsular opening. So, I started the case with a 25 gauge 3-port vitrectomy system. Once the ports were established at 3 mm from the limbus, a good anterior vitrectomy was performed. Once the anterior vitrectomy was done, I dived in and went ahead with the central, core and peripheral vitrectomy. The PVD was already present. A 360-degree scleral depression was done and lens or the cortex or the nucleus was nowhere to be found. Indeed, it was a case of spontaneous absorption of the lens. Now, the next step was to check the integrity of the anterior capsule, which was checked with the help of tryphan blue dye. The posterior capsule appeared deficit and fragile at multiple places, but the sulcus looked absolutely intact. A 3-piece intraocular lens was injected. The plan was to make sure to dial the lens in the sulcus. A viscoelastic was used for the same, and with the help of an IOL dialer and a max grip forceps, the IOL was dialed inside the sulcus. As you see, the IOL is absolutely well centralized and stable over the sulcus. Now, the posterior capsule that is underlying the central area has a very high chance of having an opacity in the future. Hence, with the help of a cutter in the retro view, a posterior capsular opening was made, and hence the chances of posterior capsular opacity was minified. The IOL looks absolutely well stable, hence the wounds were hydrated and the ports were removed. The eye appeared stable and there was no evident hypotony. 1 week later, the patient came back smiling with an improved visual acuity, a clear cornea and an absolutely stable IOL. So, the moral of the story is when you have a case of a spontaneous absorption of a lens post-trauma, there are 3 aspects which have to be very carefully monitored. Thank you very much for your time and patient listening.